Thank you for coming. I first wanted to introduce Captain Christy Butterfield from the Sheriff's Office Custody Services Bureau.
Thank you, Erica. On behalf of Sheriff David Livingston and Assistant Sheriff Matt Schuler, I want to welcome you all here and thank you. I also want to thank everyone that's been involved in making the last week of this rapid improvement event happen. Obviously, the health and mental health staff from the county, our custody staff at West County stepped up and did an amazing job. But most importantly, the community-based organizations and the community members that helped us this last week. As I said, we hosted the last 4 days at the West County Detention Facility. It was the first time they've had it there. Probably the biggest team that they've ever had, Erica told me. And during this last week, I was personally able to witness the team do some amazing work. They worked tirelessly identifying issues, but they also put the same amount of time in trying to come up with solutions to those issues, as you will see when I'm done talking to you. I saw great collaboration and teamwork with this group, and I also saw the different entities come together and listen to each other and open their mind up and learn from one another, which was amazing to see. And great outcomes were reached. As I said, you're going to see this soon. And I'm excited to see what the next rapid improvement events will bring, just from what I saw for the last 4 days. And before I let them kick off and explain to you everything that they found over the last 4 days, I want to leave you with a quote by Helen Keller. "Alone, we can do so little, but together we can do so much." So thank you guys, and I look forward to their presentation.
My name is Chris Farnatano. I'm the Director of Process Redesign, and I was part of this Rapid Improvement Event Week. Our team is really, really excited to share with you all the great work that they have done this week. So how did we get here? This whole journey started middle of last year with a value stream mapping event where a team went in, spent a week in detention health, doing a real deep dive and kind of mapping out the current process, seeing what worked well, what didn't work well, and really mapped out and envisioned a better way of providing health care to those in our community who are incarcerated. We then went from that process and we really identified some core values that we really wanted to focus on throughout this improvement work. And those are core values of dignity and privacy and safety. And those are really important for our detention patients. We also heard from our detention patients that they didn't want to be referred to by the health staff as inmates, didn't want to be referred to and thought of solely as someone based on the crime that might have brought them into detention, but they wanted to be thought of as individuals and they wanted to be thought of as patients. So we really consciously tried to, in this process, refer to them as patients, just like we would refer to an individual in the hospital or in one of our clinics as our patient. From that value stream map, we laid out a plan for improvement, and that plan for improvement started with a driver diagram which started with an aim and then a series of primary drivers or steps that would lead to that aim, and then secondary drivers that fed into that primary driver. That primary aim we came up with was one care. So to provide high quality care for patients that address all their mental, physical, and psychosocial needs and is timely, trauma-informed, culturally sensitive, and respectful. From that driver diagram, we laid out a series of rapid improvement events that would focus on different aspects of care within detention health. And we've been running these rapid improvement events on those different areas. The intake process, after somebody is booked into detention, different levels of care from emergent to urgent to routine levels of care, focus on specialty care and the types of group care that we deliver in detention, And this week we've just completed has been focused on the reentry process of patients getting back into connection with the community after they're released from detention.
Good morning. My name is Jonathan Albright. I'm with the Business Intelligence team. I was joined at this event with my team member, Rudy Chavez, to provide data services for the group. Two things that we focused on bringing at the onset of the group were to focus on questions of how many and when. And the next two charts I'm going to show you just highlight and answer that question. So how many releases occur at the detention facilities? And we could see here for Martinez Detention Facility, there's anywhere from 900 to 1,000 releases per month. West County Detention Facility, there's anywhere from 800 to 900 releases per month. The next slide answers the question of when these releases are occurring. This, as you can see, Martinez Detention Facility, most of the releases actually occur in the mornings at 7 o'clock, anywhere from 7 to 8 a.m. For West County Detention, these releases occur anywhere from 4 to 5 a.m. And the evenings at Martinez, 7 p.m. and 6 p.m. at West County Detention Facility. Thank you.
Hi, good morning. My name is David Seidner. I'm with Detention Mental Health. Thank you all for coming today and supporting us and listening to this presentation. With this work, we really want to apply improvement science and improvement principles as we are improving the care at our facilities. What we want to talk about and show you is one improvement technique, which is called a PDSA, a Plan, Do, Study, Act. What we do is one test with one service user and one provider, and we plan first. So as a team, we come together, we look at a workflow or we look at a process, and we want to make one adjustment. And then we do it. We do one adjustment. Again, we want to have small impact to our system. We don't want to disrupt the system. We do one kind of test. And then after we do the test, then we look at the outcomes and we study the data that's connected to the outcomes, and then we act. Then we make a decision, are we going to go forward with our testing? So after we do a couple of PDSAs, then we're going to make a decision as a team. Do we adopt the new process? Do we adapt the new process and modify it, or do we abandon it? Because not all testing leads to implementation. And once we're satisfied that we have enough data, enough evidence that this is a good process, then we go ahead and spread. We'll implement up to the full system. So the question for the team this week was, why reentry? And reentry for us is a passion because we know that when our patients are leaving the facility, they're going from a structured environment and they're reentering, becoming returning citizens to the community, and they're at high risk. Many things can happen during that process. And we want to make sure that we're optimized and supporting our patients connect to the countywide reentry system so they're not out there on their own without resources. What's important to us when we look at these two statistics on the slide, we know that individuals who are leaving the facility are 12 times at risk of death within 2 weeks of leaving the facility, and individuals who are leaving the corrections facility are at 3 times at risk of death after 2 years of incarceration. And again, that's very meaningful to our health team and our custody partners, that this is a high-risk opportunity that we actually want to support and address. When the teams met this week, we broke up into 3 sub-teams. So we focused on assessment, we focused on medication, and we focused on linkage and connections for the reentry process. Thank you.
Good morning, everyone. My name is Allison Stribling, and I work with Community Connect. And this past week, I was part of the assessment team. Our team began the process by gathering all the different assessments a patient inmate might complete during their stay at detention, and we discovered that this is as many as 8 different screenings that they might complete between intake and discharge planning, depending on the services they access during their stay. Based on discussions with the larger group, we decided we wanted to focus on determining which screenings assess for 3 main areas, which were medical insurance coverage, expected living situation upon release, as well as substance use history and openness to treatment upon release. After completing our mapping, we found that while all the screenings did ask about substance use history, Only the later screenings that a patient might complete during mental health or discharge planning actually ask questions about living situation upon release, openness to treatment, and medical insurance coverage. And because these screenings are only given to a subset of the patients that want to access these services, many inmates would not be screened for these reentry needs. Additionally, during the mapping, we discovered that a multidisciplinary team does work on reentry. However, they don't participate in any formal case conferencing with each other. There's no standard assessment or reentry plan that is used between all members and shared with all members. And each member enters different information into many different databases, so not all this information is accessible by all members of the team.
Hello, my name is Kimberly Thompson, and I'm a mental health clinical specialist assigned to West County Detention Facility. So while working with the assessment team, basically what we learned on every housing unit at West County Detention Facility, which is a total of, I believe, 9 housing units, there's a Medi-Cal box that's located in the common area on the unit. And that box is there because once the inmate patients complete a Medi-Cal application, they're to submit the application in a box for it to be collected by one of our outside providers, so it could be entered up into the computer. But what we learned is that the box lacked the clear instructions, so the inmate patients had no clue actually to what the box on the unit was to be utilized for. Another thing that we discovered is that there was a low number of applications that were being placed inside the box. I would say approximately there's a total of anywhere from maybe 70 to maybe 100 inmate patients that's housed on each living unit. So 2 to 3 applications, as you can see, is a very low number. And also, what we had discovered is that there was outdated material that was also placed inside the boxes, and also a lot of trash. It was being utilized, where the inmate patients was placing trash inside the area. Also, every living unit also has a board that's in the common area where information about the behavioral access line is posted, as well as the pre-release information that they can gather. However, deputies and inmate patients is not aware or informed that the bulletin board is there, so therefore is a lack of awareness where they could know how to be able to access the resources that's been made available to them.
Good morning, I'm Janet Evans, and I'm the Reentry Transition Specialist with the County Office of Education. And I was very excited to be a part of this group to dig deeper into the needs of the people that we're serving inside the jails. So some of the ideas that our team had for improvement starts about asking the reentry needs at intake. So somehow getting rid of all of those 8 assessments that have to be completed and narrowing down that number, but really starting at intake with asking those questions. And then from there, develop a standard of work for pre-release planning during the entire stay that they are with us. And that having that standard work include assessment and the plan development. We thought about establishing multidisciplinary case conferences and those happening on a regular basis so that the entire team, me, the transition specialist, and some of the clinicians together looking at a whole person and planning for the whole person instead of planning for separate parts of what their needs are. Another idea we had to do with these databases. And it's I know it's an issue in a lot of agencies, but we all use different databases and they don't talk to each other. So if someone's working on someone and I'm working on the same person to do pre-release planning, we can't see each other's stuff. It's only by informal communication. So the databases being able to talk to each other would be huge for us to do better planning pre-release while they're still incarcerated.
My name is Krista Harrington. I'm a community support worker for Contra Costa County Mental Health Financial Counseling. And with more improvement, we determined the need for additional staff for pre-release planning, to educate deputies and patients on available reentry resources, to remove the Medi-Cal boxes on the units, and instead provide education for patients to complete Medi-Cal applications in person, and to locate financial counselors within the detention facility, and also to provide outreach inside the facility during groups and during the school time, and to provide that information to the patients.
Good morning. My name is Valerie Gordon. I'm an RN working in the detention setting. I'm assigned case management duties, and part of that is some discharge planning. I'm a part of the subgroup of medications, in particular take-home meds or discharge meds. So we started looking at where are we at today, and we saw that of the 18% of patients that are in custody being treated for chronic conditions with medications, how many of them are actually going home with discharge meds? Only 3%. We said, why is that? Well, unlike in the hospital or the clinic, where you know when a patient's going to be leaving or the service is terminated, we don't know that. Of all the patients in detention, only 25% have what we call a projected release date or discharge date. And that's subject to change. So the process in detention is patient-driven. In other words, they have to request take-home medications. And then when they get to that point, we found that it's a complex system that we use. I'm sure we're all kind of familiar with when you call a business and you want to get a problem resolved and you get put on hold and transferred to this person, to that person, and then you get an hour or 45 minutes invested in it, and then they drop the call. Our system is very complex too. Thank you.
I'm Chris Farnatano again. I was part of the medication team. We mapped out and followed this whole process that started from when the patient requested pre-release medications to the physician ordering those medications, our detention pharmacist in Martinez filling those medications, and then those 2-week supply of medications being placed in the property bin for the time when the patient is released to the community so that they can get their medications with them. We learned there was a different process at West County versus the Martinez facility. That process, especially at Martinez, had risks that the patient's medications could get separated from their property and not released with them. And so that was a risk we identified and came up with plans to improve. We also learned that 14-day supply of medications isn't always enough, and that after a patient is released to the community, they often have to reactivate their Medi-Cal, which we learned that when you're incarcerated, your Medi-Cal is deactivated, and you have to reactivate it once you are released. And then they have to get plugged into their healthcare provider to get additional ongoing medications. At the same time, they're trying to struggle with their housing, their food, clothing, shelter, all their other primary needs at this time. We learned that the best practice for detention facilities across California was to give a 30-day supply of medication. So we tested a few things. Rather than relying on the patients to notify us when they're being released, we tested being proactive, and we built a report that showed upcoming releases, and we worked that report to identify patients who had an upcoming release who are on medications to notify the provider to write those prescriptions. We also came up with an even more streamlined process both a standard process for routine releases and also an ultra-streamlined process for those patients where we learned at the last minute that maybe they're being released tonight or they're being released tomorrow. How do we get them medications, maybe with a starter pack of a few days of medications, and then an electronic prescription going to a retail pharmacy like Walgreens for them to get ongoing medications. We did a test yesterday with using this report. We identified a patient who hadn't let the health team know that she was being released this coming Monday morning. She was at risk of being released without her very critical seizure medications. In this test, we were able to have the provider order those medications, get them filled by our pharmacist, placed in her property bin in under 3 hours, so that it's all ready for her. When she leaves the facility on Monday morning, she's going to leave with her medications.
Hi, I'm Sophie McCurry. I'm a preventative medicine resident working in the public health department and a pediatrician working as the provider in detention. And from what we learned in kind of our test, we came up with some ideas for improvement for take-home medications. One of the ideas was to take away the complexity for the patients to request their take-home medications, so they don't have to go to several different individuals, but one person for any, whether it's a psychiatric medication or a medical medication. Also give patients more opportunities to request take-home medication instead of the limited hour triage phone time, so 24-hour phone request line that they can leave messages and a nurse can then listen to the messages as well, but as well continue to do the triage line and the other written request. And as Chris mentioned from the test, new processes for the expedite the short notice releases that included warm handoffs to the providers to ensure that the medication did get ordered and had enough time to come to the facility. And then if needed, a starter kit and then e-prescription for a community pharmacy such as Walgreens. And also to develop and use this new report as a standardized procedure for nurses to be more proactive for patients with a projected release date, and also for short notice releases, so nurses could possibly order the medications as well. We also wanted to ensure that the medications were ordered, so provider address all requests for meds before noon. And also, as Chris mentioned, best practices to dispense 30-day take-home medications instead of 14 days of take-home medications, which was actually approved, and from going forward on, patients will not get a 30-day supply of take-home medications to support them, and there's no gaps in medication. We also, ideas for improvement is ways to, once medications are ordered and prescribed, that they actually go home with the patients, so improve that operations clerks actually are aware that medications are prescribed, so if they're missing, they can look for them, and the deputy can also check in to see if there was any take-home medications.
Good morning. I'm Christine Robbins, the AB 109 Programs Coordinator with the Sheriff's Office. I was on the Linkages and Connections team. We focused on 3 primary areas for improvement: resource access, release and transportation, and also homeless and core services. To start, in general, the telephones on the housing units are one of the primary ways that inmate patients can access reentry and health services. The phones are located in a common area, and they are available during the designated free time hours. They also have access to the bulletin boards, which you heard mentioned already, which are actually chock full of resources and information for people to connect with. However, those boards are 15 to 20 feet away from the phone bank. We took a look at one service in particular, the county's behavioral health access line, which inmate patients can access for mental health and substance abuse services. We found from our testing that half of the calls from the AODS access line were unsuccessful. They resulted in dropped calls or calls that went straight to voicemail. We also found that the calls are limited to 12 minutes, which is significantly shorter than the time it takes to conduct an AOD assessment over the phone with a counselor, which is generally 30 to 45 minutes. We also checked on the accessibility of the 211 crisis line, where we confirmed that that line is not accessible from the detention housing units at this time. Finally, our interviews with detention staff confirmed that there's some stigmatization and even some victimization that happens to folks in detention who seek out support services, and unfortunately that can be affecting their safety, dignity, and privacy within the setting.
Good morning, everyone. Michael Fisher with Health Housing Homeless Services. I got to talk about the future state of resources in detention. The future state of resources and access from detention would be clear and easy for patients to access. Improvement ideas that we came up with were a 211 quick dial from detention phones. This would give immediate access to housing and homeless services from detention. Intentionally placed resources would decrease the stigma that the inmate patients are currently facing when they're trying to access these resources. In every module, there is a kiosk, and that kiosk is a perfect opportunity to place resources that inmates could access from that kiosk. And we would like to place resources next to the detention phones so that while they're on the phone, they can be utilizing those resources as well. So we got to test. The future state of resource access could look like a test that we performed yesterday. So we came across a gentleman who had just been released at the West County Detention Facility waiting in the lobby. Our team engaged him, and we found out he was from Modesto. He had no money to use the phone, and he had no ID to take a train back to Modesto. So we attempted to dial 211 from the lobby phone and found out that it cost 50 cents to use that phone, and he didn't have 50 cents. So we used one of our own phones to call 211. We were immediately connected to core dispatch, outreach dispatch. Within 30 minutes, we had an outreach worker there to engage and assess him. And we found out that if he couldn't go back to Modesto until he checked in with probation, which he would have not had transportation to. So we provided transportation to probation. He checked in with probation. Then we took him to one of our local care centers where he was able to get a warm meal. He was able to rest, and some staff members there assisted him with family reunification, and he ended up leaving the care center back to family's house in Modesto by the end of the day. The other test that we did was we placed core members in the lobby at yesterday's 5 o'clock release at West County Detention Facility. And we engaged all of the individuals that came out of release. All of them were happy to see that somebody was in the lobby and that was there to care for them. Although none of them ended up accessing any of the resources, all of them were informed, and we were able to do a homeless assessment on one individual who is living homeless. So it was very successful.
Good morning, my name is Noelia Gutierrez. I'm with the Blue Zone team. I'm here to talk about the current state of release and transportation. So 75% of people do not have a projected release date, which does not provide them with enough time to get connected with the appropriate resources or speak to family and friends to set up a pickup. At release time, they receive bus and BART tickets, and the BART ticket is only $5.35, which isn't enough to get them from West County to East County. The peak time for release at West County is 4 to 5 a.m., which would cause them to wait out in the cold for an extended period of time until the first bus arrives at 5:55 in the morning. And if they decide they want to make a phone call from the pay phone in the lobby, they would need to have money, which not many of them have. So this does not provide them with a positive reentry experience into the community.
Hi, my name is Brandon Tomlin. I'm with Detention Mental Health at West County. So you'll see these are some quotes from people actually as we observed the release process, both at West County and Martinez. Some people at post-release, we asked questions about what their experience was, what was going on for them, and specifically around transportation, you'll see, that this is a big barrier just at release time for people getting back even to their families and back into the community, let alone accessing services. So some ideas we had for improvement around this are just, reviewing and increasing BART and bus ticket and the eligibility criteria so that people have enough to get back to Pittsburgh, to get back to Antioch, to get down to where their families are. Posting bus schedules so that people have an idea of how long they're going to be waiting possibly. And then, this is a golden opportunity in the lobby or through the possibility of an on-site trailer or a mobile resource center to engage people at the time of release and jumpstart that connection with the resources they may have had access to or worked with a reentry specialist on. But jumpstarting that connection once they're in the community and making sure they know how to reach it. And possibly giving them a chance to charge their phone or have a hot cup of coffee. At the very least, having a smiling face there, like Mike said, in the lobby to greet them and make sure they know that we're welcoming them back into the community. Thank you.
Hello, I'm Mike Callanan. I'm the CORE Outreach Coordinator with Health, Housing, and Homeless. We're going to talk about the current state of CORE and homeless services. CORE stands for Coordinated Outreach, Referral, and Engagement. CORE outreach teams meet with clients to build the trust and relationships so we can connect the clients to services such as shelters, care centers, warming centers, and which have access to showers, laundry, food, and case management services. The CORE teams also provide clients access to IDs, detox and recovery programs, medical, mental health, and dental programs, along with benefits assistance such as SSDI, GA, and Medi-Cal. Ideas for improvement. To better serve the homeless population as they are released back into the community, a CORE team can be structured to meet the clients upon release to connect them to services. CORE is easy to access if the issue with the connection with 211 on the detention facility phones is remedied. The client should be able to access CORE and 211 flyer information at multiple locations throughout the facility. By adding a flag to the JMS, which stands for Jail Management Information System, to note that the client is homeless, they then can be referred into services so we can reduce recidivism. Thank you.
Hi, I'm Bruce Heyer. I work for Contra Costa County Mental Health Financial Counseling. I'm a community support worker. After interviewing some clients, we found that unless the clients have money on their books, these were a few reoccurring quotes from the clients upon release. How do I keep appointments when I sleep under a tree? And if someone didn't put me in contact with CORE, I'd be stuck here at West County all day.
I am going to be talking about Transitions Clinic on behalf of Transition Clinic staff who couldn't be here today. Transitions Clinic is an outpatient clinic designed for individuals who are going back into the community from incarceration. And there's two clinics, one at West County Health Center, one at Pittsburgh Health Center, which meets twice a month at each clinic for individuals with chronic medical conditions. It's a multidisciplinary staff, including physicians, reentry coordinators, psychologists, and a program coordinator. And it's paired with the Remedy Support Groups, which addresses psychosocial stressors associated with reentry, and also includes a peer mentorship program. The data shows that individuals who are engaged and connected to the Transition Remedy Clinic do well. They have improved health outcomes, less emergency room visits, a large percentage of individuals have no rearrest during this time period, and they most low no-show rate as well. And a large percent of individuals have well-controlled diabetes and high blood pressure. Currently, the Transitions Clinic patients with chronic medical conditions who are eligible are not routinely being identified. And currently there's a small generated report based on a small population of individuals, the AB 100. So even through this report, only a small portion of the eligible candidates are being identified. The referral process is not accessible or well known for detention staff, and they can be referred through other avenues such as community-based organizations and state corrections, but not detention staff within our county is not doing a great job at this time. And data does show that approximately 50 patients per week who are released are eligible for the transition clinic, and currently only from the current report, only 5 to 7 people per week are getting referred who are eligible. Because of this, some ideas for improvement is to identify all individuals who are eligible for the transitions clinic, so generate a new report, and then identify individuals who are exiting detention through this report. Embed transition reentry health conductors into the detention. Currently, when individuals are referred, the staff, either a health conductor, a staff at West County, or a staff at Martinez Detention Facility, will then engage the patient to assess interest and to do a social needs assessment. There's not staff at West County that can do this. There's only one staff at Martinez that can do the assessment as well, and only one health conductor that only goes out once per week and has limited access to detention. So really this process takes about 2 to 3 weeks to assess the individual, then refer. So if they're embedded, it could be a faster process. Redesign the referral workflow, generally speaking, to include a care coordinator as well, and really make the transition clinic more of a specialty clinic. So a care coordinator to help with outreach, to help schedule patients, and to identify anything else the patients might need. Also expand the capacity of transition clinic to make it weekly at both sites, especially if there's 50 eligible patients per week, to ensure that they can get in, and to also increase staffing. So there's only 2 physicians, so more physicians and more health conductors. Also explore adding mental health staff to transitions clinic and the remedy support groups. Currently, only one of the sites has a mental health clinician facilitate the remedy health group, and the other site is a health conductor, so really increase that capacity.
Hi there, I'm Erica Jensen. I'm the Assistant to the Health Services Director with Contra Costa Health Services. Thank you all for being here. I get to talk about what great work the team did. So you can see some of the accomplishments and they talked about them. So streamlining the medication process, making it shorter so that people can get their medications when they leave is a critical piece of making sure that people stay healthy. Mapping out the process of all the different assessments, all the different questions that patients get asked along the way is not a small process if you saw the all the Post-it notes, all the flip charts that the team had. Testing the core team, having the core team come, calling them, but then also having them on site was really miraculous for people in the lobby, I have to say. Michael didn't talk about this, but I went downstairs to the West County lobby. I was leaving the building. We had a bunch of donuts. We tried to offer them to a lot of people. The core team said, yes, we'll take them. We'll take them back to the office. But first, I offered them to people in the lobby. So there were family members in the lobby who had been waiting for over 6 hours for their person to be released. And they said they hadn't had anything to eat that day. So I want to call out the importance of engaging both the community as well as the family members with providing resource information and reentry information to families. The other thing that the core team told me was that although no one particularly wanted services, when one man came out of the door, he gave them a humongous hug. He was just so happy to have someone there greeting him when he left the facility. So I think for me, that was a really important part of the week, was really about making the connections. And in terms of bringing the underutilized resources to light, so we have financial counselors in behavioral health that can help our detention patients get their Medi-Cal reactivated. We have the transitions clinic. We have an outpatient clinic for people who are formerly incarcerated. We have the behavioral health, mental health, and substance abuse services. We have Community Connect, which provides case management services, wraparound case management services, and we have CORE. We have all of these resources within the health department. So I think the task that the team took on this week was really about how to actualize that connection, how to make those connections and how to make them real for people. The other thing that I feel like we sort of tasked the team with being detectives, right? Kind of finding out what's happening here, and then also improving. And part of the detective part was to bring people together who normally work together but don't really understand what each of them do. So Deputy Forsyth, who couldn't be here today, was an integral part of the medication team. And yesterday he said, I learned so much about the medication process. I was a stranger in my own facility. And he was someone who had worked there for 20 years. He didn't understand what the medical staff did. He didn't understand sort of the process of getting take-home meds put together. And he said, now when I see that brown paper bag in property, it's 10 times more important than I thought it was. So that, I think just having an appreciation for all the work that goes on in detention, and then also being exposed to all the work that happens outside of detention and all the resources that are available was very important. So I think it's an understatement to say the current state is complex and difficult to understand. We had a team, the largest team that we've had in a rapid improvement event, so almost, I think, more than 20 people, and it took us, we're not even finished understanding the current state, frankly. I started talking to people about reentry actually back in August, because when we did our current state map of what's happening, we had one little box for reentry, because we knew it was really complex and we couldn't do it within that week. There are so many processes that go on in detention around pre-release planning and reentry, and there's so many partners outside in the community that are serving our patients who are formerly incarcerated. So the Office for Reentry and Justice, Health Right 360, the Reentry Success Center, all the community-based partners are out there. And during this week, we could only really think about the health partners because we wanted to make those connections first, but there's a much wider net that is out there that I think those connections could be made. I think, learning the whole process. So I think the other piece that was really important was the custody participation. So detention is a custody environment. Health is there to provide services, and it is extremely important for health and custody to partner. We had amazing custody participation during this week. So Captain Butterfield and Lieutenant Andaya welcomed us into West County Detention Facility. We took over many of their spaces. They were very kind to us. But also the staff that work in custody were so excited to be able to make improvements and to be able to partner with the health staff to go look at these Medi-Cal boxes, to get these medications in the right place, to talk to operations about where can we put the medication so they'll get to the patients. The person-to-person connection, I think, was really important for pretty much every member of our team, whether they connected with someone who was on the team, whether they connected with someone who was in the facility, or whether they connected with someone who had just gotten out of the facility. So we talked, as you heard many presenters today, about dignity, privacy, and safety, and we take these very seriously. As a health staff, I'm constantly learning about safety in the custody environment. So asking about the 211 number to be available from the detention modules, that's a security thing. I talked to people in custody about that. So that was a barrier that we didn't know about and that we're going to try to remedy. So I think that this is the other reason why it's really important to partner with custody. So we have all these improvement ideas, like for instance, the boxes for the medical applications, that may or may not work. And if they fail, that's fine. Then let's do another idea to be able to get the services to people. So this is a quote by Jada Pinkett Smith, who's an actor. I have a thing for doors. I always think of them as a threshold to something new. So I think what we've been doing in this detention health improvement process is really thinking about detention health from the time someone enters the front door till the time they leave. And I think what we've been doing in this particular week was opening the doors for our team, opening the doors for our patients and community members who walk through those doors many times. So you saw that there are more than 2,000 releases a month from detention. That is an amazing opportunity for us to greet people as they come out that door, to connect them first when they come into the door of detention, we have just an unprecedented opportunity to be able to connect people to services that they may not have had, or to continue the care and services that they may have been getting already. I think also for the team, many people walked through the door in a different way. So going to custody, there's a lot of doors to get in for staff, right? And there's a lot of doors to get out. So just the feeling of the team of having to be escorted everywhere is a different feeling, and gives you the feeling of what it might be like to be a patient in a facility that is a locked facility. I wanted to thank a bunch of people. So I wanted to thank the West County Detention Facility health and custody staff, as well as the Martinez Detention Facility staff. So we went to both West County and Martinez to observe processes. We didn't get to go to Marsh Creek yet, but we're gonna get there. Not only do the staff welcome us, but the staff who actually do the work during that time end up having to do more work because their team members are off understanding the process and making improvements. So I think it's really important to acknowledge the staff that keep the operations going while we're making these improvements. Our subject matter experts. So our data team was with us. You heard John present, and Rudy, they were with us every day. We would go up to them and say, we need to know about this, we need to know about that. And having access to data to be able to test our improvements and understand what the real problem is quite amazing. I also talked to a number of people before this event in the community. I talked to the Behavioral Health Care Partnership. I talked to Patrice from Health Right 360 about kind of all the issues around families, about reentry, and I think that made our week better, as well as our patient and family advisors. Our sponsors, Anna Roth, our Health Services Director, and Matthew Schuler, the Assistant Sheriff. And our leadership support team. So usually in the past, we've done these events in Martinez, so the leadership support team comes there. This time, the leadership support team came to West County and got to see a little bit of that facility and got to see what we were doing. And we appreciated them showing up every day at 4:30. Even though it might have meant extra traffic and a different commute, I think it showed how committed people were to this process and how supportive of the changes that we want to make happen in detention. And I just want to give a particular shout out to the team. I think it was an up and down week. This work is very hard. It's hard to understand what the current state is. It's hard to get out of your own discipline. It's hard to go into a totally perhaps new environment. So I wanted to acknowledge just all the hard work that the team did, all the improvement ideas that maybe we didn't get to test, but that I hope will be tested in the future, and just how proud I am of the work that you did and the presentation today. So if you could stand and we could give them a round of applause, that would be great. Thank you. And now I'd like to introduce Jaspreet Benapal, our CEO of our hospital, ambulatory care clinics, and detention health.
Good morning, everybody. I'm Jaspreet Benapal, interim CEO for the hospital health centers and detention health. So, like Erica said, this is really complicated work. And what I saw and what was excited about when I saw the teams, not only we looked at how complicated it is to provide these services to our inmates in the detention facility, but also how complicated, the services that are available for them, how they are not available at the time when they actually need them. But the teams came together, they learned together, and they worked together. And I really would like to thank you, the staff from Sheriff's Office, Public Health, Transition Care Team, H3 Team, Community Connect, Business Intelligence Team, Reentry program, financial counseling department, behavioral health, public health, and if I'm missing any other department, I apologize. And most of all, I want to really thank the patients who actually participated in this. I know Erica went at 4 a.m. to talk to some of the patients who got released early morning and were waiting in the rain. And it really touched my heart when I read some of the quotes. Things that we take for granted, those are not there for them. And 50 cents that we don't even pay attention to is really a big difference to them to have those services available so they don't go back to the place they came from. A phone call to their family member, not having that 50 cents, not being able to, have their phone charged. Some of them have their phones, but they are booked. So by the time they get released, their phones are dead. No charging stations. We don't even think about these things in our daily lives, but those things are so essential to those patients. And I'm so glad, and I want to thank the team that really took the courage to come together. And all these teams, probably, I think, not all of them, but some of them met each other for the first time. And they learned about their workflows for the first time. And it really, it touched my heart to see how compassionate the staff members were, things to provide one care. Why do we even have to go there? It should have always been like that, but I'm glad we are there. Privacy, dignity, safety that we have in the hospitals, now it's going to be in our detention facilities, and I'm so proud of the team and the staff and the community and the patients that are working towards that one goal. Thank you, guys. I really appreciate all of you guys here. Thank you.
Good morning. What I was typing are all the other things I need to do now. As well, and that's real. I really appreciate opportunities like this where I get to continue to learn, and I'm humbled by that process. Whenever I can hear from everyone and all the various pieces of the puzzle we all carry, I think it reaffirmed for me the power of one. And in this case, the power of one is everyone's willingness to actually take their little piece and put it together to create one cohesive picture and a goal that comes out of that. And so my notes were really about what do I need to do to support this continued process, and that whatever is adopted gets sustained, because that's really the important part. Right? So I want to thank particularly the H3 staff that was part of this process, because what you may not know is even though after they've participated in this process, they're still getting phone calls every day. And those core outreach teams who are operating at night till 1 a.m. in the morning, they're still on call. So even after all of this process, I know that they were still doing much, much more work. And so I want to give a special thank you to Michael, to both of our Mikes for that. And just, again, the ability and the willingness of everyone to come together through this process. My work is now beginning. So thank you for that.
So it turns out that every system is perfectly designed to get the results it gets. And I think you guys proved that. That is a quote from, we can argue, I'm from the IHI, and the IHI, the Institute for Healthcare Improvement, and we argue about the origins of that quote. But I like to say it comes from Don Berwick. And because it really is true that what's happening, our system was designed for this for things to happen or to not happen. And even if we really want it to change, it turns out it takes a lot of hard work to change it. And so I want to thank the team for putting in the hours to really take on some of these assumptions. I mean, things like who knew that 211 didn't work at the jail? Did we know this? I don't even know. I didn't know. I think Jaspreet's point of the things we take for granted, like who has used a payphone in the last 3 years? So these are real things that, we're really not designed anymore to address. And it's like we were talking about, it's like being dropped into like 1974 or something. And we're just not prepared to respond to these systems that we now have to sort of catch up and redesign and fix. I want to thank, I know Employment and Human Services also came out, so I think that the audience that's sort of out here today, and I know is a small reflection of a broader group that are really have been invested in helping redesign healthcare in the detention sites, is really, I think, one of the more diverse. Today, I think we have even a more diverse group of people than we've had in the past, and it has been one of the more, I think, diverse sort of improvement efforts that we've done. We have people from the community, we have people from all across county departments, health, sheriff's office, the public defender, county council. We have Employment and Human Services, as I said, and I think there are others I know that I'm not mentioning, and I hate to do lists because I always forget somebody. But I want to thank all of you, because we know is that health can't do this alone, and it takes a lot of courage to do this kind of change. And I want to acknowledge the sheriff's office for taking this journey with us. It's I actually descended. I didn't go to all the leadership afternoon sessions because I'm trying to take on a new role. I'm the health director now as of February 1st, so Jaspreet is now the CEO, and so I'm kind of moving into a new role. But for those of you who know me, you know I can't stand for an improvement event to happen and not to be in it. So I did descend on the team day before yesterday for what was meant to be 10 minutes. Maybe it was an hour or so. And I really got to, I had the opportunity to listen to them sort of taking down these walls and these barriers one by one inside of detention, and actually outside, the parking lot, the bus stop, the lobby. I want to I want to acknowledge Sergeant Shields, who was, and I know that this must have come up many times before in the week, but for me, when I came, the person who really put the stake in the ground around stigma and the role stigma is playing was Sergeant Shields. He said, I'm not sure it makes sense for us to expect people to go out into the module during free time and ask for services that could put them in a compromised position. And, we should think about that. And then Deputy Forsyth said, I'm the last person everybody sees. And they're in a very different mindset when they're walking out the door than when they're inside of the module. And you guys are welcome to be part of that space. You can come into the space that I'm at, where people are really open to, they're kind of thinking, they're optimistic, they're walking out the door, and this is an important time to leverage. And so I feel like all of the staff came together to start thinking about what's happening from the perspective of the patient, and the people who are incarcerated, like what's happening, and does it really make sense to have the information over here when maybe it might be better received over here, and watching the team just make small adjustments, moving information 15 feet, or moving release planning to intake, and starting to think differently about this system. Right, the system that was designed to get these results, and I think we can all agree, even though I know we have there's probably a wide set of perspectives in this room. We can all agree the data that we saw up there, we can do better, and so I want to thank the team for really taking that on. These kind of tests, these are dynamic, just so that kind of to give an example, the 211 fix. They were working on that from Wednesday morning until I think they've started to test now. The solution has gone into test this morning, I think. I'm not sure about that. The 30-day med supply, I was texting Chris at 5 p.m. or 6 p.m. last night to give approval so they could start those tests. I mean, he was emailing me at like 3 o'clock saying, do I have the approval, yes or no? I need it in writing. It's like a true, where are you, Chris? Oh, there he is. Yeah, I want it in writing from you because I'm going to put this in place like immediately. And so, there's a lot of wheels that are spinning outside of the room, outside of the improvement team's room that are going. And so I want to thank, all of the leaders who assemble, because they are assembled. Lavana and I talked multiple times this week. Jess Breet and I spoke with the system level CFO. I talked to the assistant sheriff and the sheriff's office. There's a lot of leaders that are sort of standing by, getting ready to remove barriers for the team. And so I want to acknowledge those people who have made this a priority to support this transformation. I also want to acknowledge, I didn't hear it acknowledged yet, but I want to acknowledge Roberto Vargas, Chris Farnatano, and Erica Jensen, who are our improvement advisors. And I want to just pause for a second and give them a hand. It's hard to lead these this kind of. So they approach each one of these improvement events with sort of very high curiosity quotient. They always come in and they have their get it done. The harder the challenge, the happier they are. It takes a special sort of person to do that, to kind of live in that all the time and thrive in that, because they're always sort of trying to figure out the glass half full, the pivot, that where they don't disrupt something to a point where people start feeling really nervous about the change. They are masters at making a pivot that actually results in better care for our patients. It's true, Erica did arrive. I think Erica and I, we generally on these weeks, we talk at about 6 a.m. every morning, and she was at the bus stop, and she was interviewing people and getting quotes, and she was, making all kinds of observations, and that's what these teams are doing. They go and they see what's really happening in the environment. I wanted to just sort of call out and thank everybody for hanging in here. We started in August, we did a value stream mapping, and then we sort of laid it out, and it always looks really neat. You put it on a driver diagram. We mapped out, like, this week we're gonna do intake, and this week we're gonna look at emergent, and the next month we'll do routine, and then we'll do specialty, and it really all fits in a nice one sheet, on an A3 or a piece of paper, one sheet piece of paper, if that's the way you view it. And that's not really the way it actually works. Improvement is not linear, and it doesn't exactly work that way. So I just kind of wanted to give you all a little, do a little reality setting that we are definitely going to have to come back to reentry. And we knew this by Monday afternoon. I think Erica said we're going to have to value stream map reentry. There's that much going on. And so I think they started doing some of that this week, and we knew that. And so I want to just appreciate how complicated this is, and appreciate that even though we're still taking the path that we set out, I think you're going to start to see, this path sort of start to take shape, and certain areas that we feel like are very ripe for opportunity for change, like reentry, and I think medication. We know that those may take more than 1 week. In fact, they may take several weeks to do, and in fact, we may, return to them almost every improvement event. And so I just wanted to call that out. But I wanted to thank the team personally for all the work you did and for welcoming me into your team process. I know that I have a lot of enthusiasm around this, as you guys can see, but I think the work that you do takes a lot of discipline. It takes a lot of courage to do, and it's really easy to jump to sort of the solution and to think that we know the answer, right? And what you guys really are proving that all big change starts with one small test. And I want to thank you for conducting those small tests on behalf of everyone we serve. The suffering that you're addressing and that you're eliminating is truly remarkable, and you are affecting countless lives in Contra Costa County, and I just want to thank you personally for that. So thank you so much for all you do. I really look forward to seeing these changes take shape and the work ahead. Thank you.